Welcome back to Radonc Smart Review Thoracic Edition.
Glad to be here. Looking forward to getting into it.
Yeah, me too. Because honestly, imagine a single millimeter of tissue on a CT scan completely changing a patient's survival curve.
Right. It happens all the time.
Or a really subtle glowing spot on a PT scan dictating whether that patient is going to the operating room for a curative resection.
Or spending the next 6 weeks with us down in the radiation vault for definitive chemoradiation.
Exactly. I mean, that is the reality of what we are dealing with today. So we are looking squarely at thoracic imaging and AJCC version 9 TNM staging.
Which, just for context, is directly derived from that massive IASLC 9th edition database.
Right. And the tone we really need to set right out of the gate for you listening is this. Staging is not, well, it's not a clerical checkbox exercise.
Oh, absolutely not.
It is not flipping to the back of a textbook and doing a quick matching game. It is this highly complex and honestly often really frustrating clinical skill of taking a stack of totally imperfect imaging studies and translating them.
And you're trying to translate them into one transparent, version-correct anatomic stage.
Yes, exactly.
And if you're sitting at a workstation treating this like a multiple-choice test where you were just forced to circle an answer even when the data is blurry,
Yeah.
you are doing it wrong. I mean, the mindset shift that has to happen, especially for those of you presenting in multidisciplinary tumor boards, is understanding that missing data is never negative data.
Right. Just because you don't have it doesn't mean it's negative.
Exactly. If you don't have the scan, the disease doesn't magically disappear just to do you a favor.
I wish it did, but it doesn't.
Right. Furthermore, an imaging impression like, say, a bright SUV avid node on a Peton scan, that is metabolic suspicion. It is not pathologic proof.
Because inflammatory macrophages consume glucose too, right?
Oh, heavily. They glow right up on the scan. A patient rarely, if ever, arrives with this perfectly curated set of scans that cleanly answers every single staging question we have.
Yeah, that is exactly what happens in the real world. I mean, the contrast-enhanced CT might give you this beautiful high-resolution anatomic definition of the primary lung mass.
Which is great.
But then, the PE scan reveals intense uptake in a mediastinal node that measured totally normal by size criteria on the CT.
We see that weekly.
Or a routine staging brain MRI catches like a 3-millimeter asymptomatic finding that completely derails the entire M category.
Right. And if your approach is just to glance at the radiologist's impression and just, slap a Roman numeral on the chart,
Yeah.
you are going to bake structural errors into that patient's treatment plan from day one, and those errors compound.
They really do, which is why we cannot talk about staging in the abstract today. We really have to anchor this to the reality of the clinic.
I completely agree. Let's ground this.
So let's bring in our anchor case for today's discussion. Imagine you are sitting at your desk, you're prepping for tumor board, and you are reviewing a patient who presents with biopsy-proven non-small cell lung carcinoma.
Okay, classic presentation.
Right. So I pull up the contrast-enhanced chest CT first. I see a dominant pulmonary tumor in the right upper lobe.
Got it.
But, and here's the catch, as I scroll through the lung windows, there is a second completely separate tumor-appearing nodule sitting right there in the exact same lobe.
Okay, so we note that. That's critical.
Yep.
Next, we pull up the fluorodeoxyglucose PT-CT to evaluate for regional and systemic spread. So the primary mass and that second nodule, they're both avid.
Makes sense.
But then we look at the mediastinum, and there is avid uptake in 2 ipsilateral mediastinal nodes.
Oh.
And here is the controversy. And honestly, if you attend thoracic tumor boards, you see this exact fight play out constantly.
I already know what you're going to say.
Right. Reader 1, the person who dictated the initial PT report, calls this multi-station N2 disease.
Okay.
But Reader 2, a thoracic radiologist who is overreading the case specifically for the conference, looks at the exact same images and argues that both of those avid nodes are actually clustered within a single nodal station.
Wow, okay. And to round out our data set, let's say the distant staging workup is technically adequate and complete. We have a dedicated thin slice brain MRI, and it is negative.
Beautiful.
And there is no distant metastasis anywhere else on the PT-CT. So for you listening, here is the puzzle we have to solve today. What is the accurate version 9 clinical stage for this patient?
Right.
What specific elements of that stage remain provisional? And crucially, what exact discrepancy absolutely must be resolved before any attending signs their name to a treatment plan?
It's such a great case because it highlights everything. But before we can even attempt to assign a stage to that anchor case, we have to build a repeatable framework.
A staging workflow.
Exactly, because if you look at that case and your instinct is to just immediately jump to the end and say, well, it's got mediastinal nodes, so it looks like a stage 3.
Which people do all the time.
They do, but you are committing a massive cognitive error if you do that. You will start like subconsciously forcing ambiguous findings into that stage 3rd bucket.
A confirmation bias.
Exactly. Instead, we use a very rigid 6-move staging workflow.
Okay, let's walk through it. Move number 1 is establishing the governing edition. So we are using AJCC version 9.
Yes, and I cannot stress enough the danger of silently reusing old AJCC 8th edition diagrams for current patients.
Oh man, we see it all the time. A resident or honestly even a busy attending just pulls up whatever staging matrix ranks first on an internet search.
Right, or they rely on a table they memorized 5 years ago during their boards.
Yeah.
Doing that is basically clinical malpractice in the modern era. An anatomic stage completely lacks meaning if it don't have an addition attached to it.
Because the goalposts move.
Exactly. Stage 3 AA is not a biological absolute. It is a statistical grouping based on global survival data. When the ISHC updates their database with thousands of new patient outcomes, the survival curves shift.
The descriptors change, the groupings are redrawn.
Exactly. Version 9 changed several highly consequential subdivisions that will directly alter whether a patient gets surgery or radiation. And right alongside declaring the addition, we have to explicitly state the power of the prefix.
Okay, yes. The C versus the P. We have clinical staging, denoted with a C, and pathologic staging, denoted with a P.
Right.
Clinical staging is your pre-treatment roadmap. It is based on the patient's history, the physical exam, the imaging, and a limited diagnostic biopsy. So you build a CT, a CN, and a CM.
And here's the nuance that often gets lost in busy clinics. Those prefixes can, and frequently do, coexist in the exact same patient record at the exact same time.
Wait, break that down for us.
Sure. Let's say a patient with early-stage disease goes straight to a lobectomy and a mediastinal lymph node dissection.
Okay.
The pathologist looks at the resected tissue under the microscope. You now have a pathologic T, a PT, and a pathologic N, a PN.
Because you actually have the tissue in a jar.
Exactly. But what about the M category? Unless the surgeon also biopsied a distant metastatic site, which, I mean, they wouldn't in this early stage scenario, the distant evaluation remains purely based on imaging.
Right. The PET and the MRI.
So it remains a clinical M, a CM. Do not flatten all that nuanced diagnostic certainty into one unlabeled guess just to make your note look neat. You have to state what each component is actually based on, like PT, PN, CM.
I love that. But let me push back here with a quick reality check from the tumor board trenches.
Okay, bring it on.
Because we can sit here and talk about pure prefixes all day.
Right.
But when we are all sitting in that room looking at the scans, the conversation just blurs instantly.
Oh, it gets so messy.
Right. The thoracic surgeon will look at a tumor abutting the aorta and say, it's unresectable, so it's a T4. Or a medical oncologist will look at a patient's really poor pulmonary function test and say, well, they aren't an operative candidate, so they are stage 3.
Yeah, that happens at every board.
So how do we, specifically as radiation oncologists, keep the boundaries clean between anatomic TNM staging, medical operability, anatomic resectability, and radiation feasibility?
Honestly, that is the most important conceptual boundary you can maintain as an oncologist. Those terms are heavily related, obviously, but they are absolutely not synonyms.
Right.
TNM staging is strictly anatomic. It is a geographic classification of where the cancer cells are physically located in the body. That is it. Geography.
Geography. I like that.
Medical operability, on the other hand, asks a physiologic question. Can this specific patient's heart, lungs, and performance status actually tolerate the insult of general anesthesia and a major thoracic operation?
Which has nothing to do with where the tumor is.
Exactly. Now, anatomic resectability asks a purely surgical question. Based on the tissue planes, can a surgeon physically And finally, radiation feasibility asks a physical and technical question. Can we design a safe radiation volume that delivers a tumor ablative dose without exceeding the tolerance of the spinal cord or the heart or the healthy lung?
So treatment selection is basically juggling all of those at once.
Yes. Treatment selection requires integrating all of those anatomy, physiology, pathology, and patient goals. But you can never, ever let surgical judgments or radiation constraints corrupt the pure anatomic TNM assignment.
I see.
An unresectable P3 tumor is still a T3 tumor. It does not magically become a T4 just because the surgeon happens to not be able to cut it out.
Man, that clarity is what prevents bad medicine. So let's lay out the full 6-move sequence so you have this locked in your mind every time you open a chart.
You see it.
Move 1, confirm diagnosis security. Move 2, decide imaging completeness. Move 3, assign the T category independently. Move 4, assign the N category independently. Move 5, assign the M category independently. And move 6. Only after you have the triplet, you translate it with the version 9 card.
Notice the discipline there. Translating the stage group is the absolute final step. You don't skip ahead. So let's dig into move 2, imaging completeness. Because completeness is always question specific.
What do you mean by question specific?
Well, in thoracic oncology, we require multiple imaging modalities because literally no single machine is capable of giving us the whole truth.
Exactly.
Yeah.
I mean, a contrast-enhanced chest CT is completely unparalleled for defining the primary tumor's anatomic relationship to the surrounding structures. The pleura, the airways, the chest wall, the great vessels.
It gives you the structural map.
Right. And if the technologist shoots the field correctly, it surveys common upper abdominal metastatic sites, too, like the liver and the adrenal glands.
Right.
But a CT scan is functionally just measuring size and shape. It tells you a node is, say, 12 millimeters, but it cannot tell you if that 12 millimeters is packed with cancer cells or just reactive lymphocytes from a recent bout of pneumonia.
Which is precisely why we overlay the PT-CT, right? We need to acquire whole-body metabolic data. The P-scan can reveal nodal or distant disease that is completely normal by size criteria on the CT.
It's the functional overlay.
Exactly. But here is the trap that catches trainees every single time. Metabolic activity does not equal malignancy.
Say that again for the people in the back.
Right. Granulomatous disease, infection, inflammation, they all consume glucose and they glow brightly on a PT.
They really do.
And conversely, absent uptake is not a cast iron guarantee of absent disease. Small volume disease or certain histologies like mucinous adenocarcinoma, they can be completely PT invisible.
Which brings us to a crucial conceptual distinction you just have to internalize. The test was performed does not mean the clinical question was answered.
That is such a good way to phrase it.
Think about the brain MRI. The brain utilizes massive amounts of glucose natively, just functioning day to day, so a body PT scan is practically useless for evaluating brain metastases. It just looks like a bright light bulb.
Exactly. A negative PET does not equal a negative brain evaluation. You must order the dedicated brain MRI.
Right, but what if the patient is claustrophobic or they are in pain and moving constantly in the scanner, and the radiologist notes that the MRI study is severely motion degraded?
Yeah, that happens a lot. In that scenario, yes, the billing code was dropped, the test was technically performed, but the fundamental clinical question, is there metastatic disease in this patient's brain? That remains entirely unanswered.
It's useless data.
Exactly. And that leaves your M category provisional, not negative. You cannot just confidently check the CM0 box and proceed to curative intent treatment based on a blurry scan.
So what do?
You have to document it. You write, brain imaging was obtained but is non-diagnostic due to motion. Therefore, the M category remains provisional pending a repeat study under anesthesia or a high-quality contrast CT.
To manage all this data, I actually like to build what I call a staging imaging inventory right at the workstation before I ever try to assign a letter or a number.
I love that. How does that work?
I look at the primary tumor, and I list every single feature that could potentially elevate the T category. The maximum diameter in any plane, the proximity to the mainstem bronchus, pleural contact, and the presence of any separate nodules.
Super thorough.
Yeah. And then for the regional nodes, I list suspicious findings by specific anatomic station, not just counting the number of glowing dots on the screen.
We'll get into why that's so important in a minute.
We will. And for distant metastasis, I list any pleural abnormalities, contralateral lung nodules, and suspected extrathoracic organ systems.
And the final critical step of that inventory is labeling every single finding you just listed with a degree of certainty. Like, is it confirmed, probable, indeterminate, or unlikely?
Yes, exactly.
And you must rigorously identify which of those findings actually have pathologic tissue confirmation. Building that inventory prevents the classic, devastating tumor board communication breakdown.
Oh, where the radiologist says one thing and the oncologist hears another.
Yes. The radiologist says there are 2 enlarged N2 nodes, and the oncologist hears there are 2 involved N2 stations. As we'll see with version 9, confusing those 2 concepts will completely derail the stage.
It really will. So with our imaging completeness verified, we move to step 3 of our workflow, analyzing the primary tumor, the T category.
Right.
We need to look at how pure size and local invasive features interact in version 9. The broad size framework is fairly intuitive. It's based on those massive IASLC databases tracking where survival curves naturally separate. Let's quickly review those size cutoffs.
Sure. The breakpoints are very strictly defined. T1 tumors are 3 centimeters or less in greatest dimension. T2 extends above 3 centimeters up through 5 centimeters. T3 extends above 5 centimeters up through 7 centimeters. And T4 is anything strictly greater than 7 centimeters.
Very clean. But size is just one avenue to a T category. Local modifiers can entirely override the tape measure. You could have a tiny peripheral 2.5 centimeter tumor. If you only look at size, that is a T1. But if the pathologist confirms that tumor has invaded the visceral pleura, the inner lining of the lung, or if the imaging shows associated atelectasis or obstructive pneumonitis extending to the hilum and involving part or all of the lung,
then that size rule is completely overridden.
Exactly. It immediately becomes a T2 category based on the local extension feature. Because, biologically, a tumor that can breach the pleura or block an airway is behaving way more aggressively than its size suggests.
And this is where the real board skill and the real clinical skill lies. It isn't just looking at a central tumor and guessing, oh, it looks big and central, it's probably a T3. The skill is identifying the exact anatomic descriptor.
Like what?
Like, is it invading the phrenic nerve? Is it invading the parietal pericardium? You have to find the specific descriptor that definitively controls the category.
Which brings up a very common, highly debated dilemma in practice. Let's say we are looking at a scan together. The lung tumor is situated right up against the chest wall.
Okay, we see this all the time.
The fat plane is just obliterated. It is physically touching the chest wall. But there is no obvious bone destruction or frank soft tissue mass extending between the ribs.
Right, it's just a budding.
Yeah, it's genuinely hard to tell if it's just abutting the chest wall or if it's actively invading it. The surgical instinct is so often, well, it looks stuck. I'm going to have to take an unblocked chest wall with it, so let's just call it T3 chest wall invasion to be safe.
Which is a very natural instinct for a surgeon.
Right. Doesn't false understaging hurt the patient more by undertreating them? So shouldn't we just call it T3?
Absolutely not, and we have to vigorously resist that instinct to overcall ambiguity. Contact is not invasion. We cannot conflate the two anatomically.
Okay, elaborate on that.
If you look at the high-resolution source images, and the distinction between abutment and invasion remains completely unresolved, even with complementary imaging or dynamic respiratory maneuvers, you do not automatically select the higher T3 category just because it feels safer to plan for the worst.
Why not?
Because false upstaging is every bit as harmful to the patient as false understaging. If you falsely label an abutting tumor as T3 chest wall invasion, you might inappropriately alter their systemic therapy regimens. Or you might cause a surgeon to abort a potentially curative standard lobectomy because they mistakenly believe a massive chest wall resection is required.
Oh, wow. I see. So what is the concrete clinical action when it's ambiguous like that? How do you actually write the note?
You use calibrated, transparent language. You document the competing interpretations directly in your assessment.
Give me an example.
You write something like, this mass is at least clinical T2 based on size, with imaging concern for possible T3 chest wall invasion given the loss of the fat plane. Or, even better, you name the specific finding or test that would resolve the competing categories.
I like that.
Right. You keep the uncertainty visible so that the surgeon knows exactly what they need to evaluate intraoperatively before making an irreversible cut.
That makes perfect sense. Honesty about our diagnostic limitations is way better than false precision. Now let's talk about separate pulmonary nodules.
Yes, like
because
this.
these are incredibly common. They represent a really complex biological phenomenon, and they strictly control our anchor case today. We use a very straightforward high-yield mnemonic for intrapulmonary nodules to quickly retrieve the version 9 rules.
The good old mnemonic.
Yep, same 3, diff 4, contra M.
Let's unpack the anatomy behind that mnemonic. Same 3 dictates that a separate, related tumor nodule located in the exact same lobe as the primary tumor is a T3 descriptor.
Right.
Diff 4 dictates that a separate related tumor nodule in a different ipsilateral lobe, meaning it is still in the same right or left lung, but has crossed lobar fissures into a different lobe. That is a T4 descriptor.
Got it.
And contra M dictates that a related nodule found in the contralateral lung, meaning the opposite lung completely across the mediastinum, is an M1A descriptor.
I really want to highlight the specific word you're using there, related. This mnemonic fundamentally assumes that the second nodule is the exact same malignancy as the primary trachea, a true intrapulmonary metastasis.
Right, that's the underlying assumption.
Because biologically, a same lobe metastasis likely represents local lymphatic transit, hence T3. A different lobe metastasis represents broader interpulmonary lymphatic spread, hence T4. And a contralateral nodule often represents hematogenous spread or broad pleural seeding, hence M1A.
Makes perfect biological sense.
But, and this is a big, but multiple lung lesions are not automatically metastases of each other. They could be synchronous, biologically distinct primary lung cancers.
Which changes everything.
Entirely. And if that possibility exists based on the ground glass morphology on CT or the timeline of growth, you have to document those competing interpretations. You cannot just lazily force every second nodule you see into a metastatic TNM framework just because it's intellectually easier to deal with one stage instead of two.
Exactly. Determining whether a nodule is a metastasis or a synchronous primary requires a really nuanced review of the histology, the radiographic appearance, and the multidisciplinary consensus. But for the sake of staging mechanics, let's apply the T category rules to our anchor case.
Okay, let's look at the case again.
We have a biopsy-proven dominant mass in the right upper lobe. We have a second tumor-appearing nodule in the exact same right upper lobe.
Right.
Assuming the tumor board consensus is that this represents an intrapulmonary metastasis of the same lung cancer, that same lobe descriptor strictly controls the T category.
Meaning it is locked in as a clinical T3. It absolutely does not matter if the dominant mass measures only 2 centimeters, which would normally just be a T1.
Right, size doesn't matter here.
The presence of that related same lobe nodule completely overrides the size rule and elevates the primary designation to clinical T3.
Okay, so with the primary tumor secured as CT3, we progress to step 4 of the workflow, evaluating the regional lymphatic spread, the N category. And we really need to pause here.
Yeah, this is huge.
This is where we have to discuss the version 9 nodal revolution. This is undoubtedly the most clinically consequential structural change in the current staging system.
Before we get to the new subdivisions, let's define the broad buckets of thoracic nodal drainage, just to set a baseline.
Good idea.
N1 refers to ipsilateral parabronchial, hilar, or intrapulmonary nodes. Essentially, these are the nodes situated within the lung parenchyma itself, or right at the root of the lung on the same side as the tumor.
Okay.
N2 refers to ipsilateral mediastinal or subcarinal nodes. These are deeper in the central chest, right between the lungs, tracking along the trachea or under the carina, but still on the same side as the tumor.
Right.
And N3 means the disease has crossed the midline over to contralateral mediastinal or hilar nodes, or it has traveled superiorly out of the deep chest into the scalene or supraclavicular nodes in the lower neck.
Those broad geographic buckets N1, N2, N3, they have existed for multiple staging editions. That hasn't changed.
Right.
The critical practice-changing version 9 update is the official subdivision of N2 disease into N2A and N2B.
Wow.
The IASLC data clearly showed that not all N2 disease behaves the same biologically, and their survival curves split significantly based on the volume of mediastinal involvement.
And this subdivision is exactly where people get tripped up constantly in clinic.
Here is the absolute rule you must memorize. N2A designates involvement of a single ipsilateral mediastinal station or an isolated subcarinal station. N2B designates involvement of multiple ipsilateral mediastinal stations with or without subcarinal involvement.
The fundamental key to getting this right, and I can't emphasize this enough, is understanding that we are counting anatomic stations, not individual lymph nodes.
Right. The most effective way to visualize this is using a rooms versus furniture analogy.
Oh, I like this one. Explain it.
The official nodal stations on the lung staging map, like, say, the lower paratracheal station 4R or the subcarinal station 7, those are the rooms in a house.
Okay, the stations are the rooms.
The individual lymph nodes are the pieces of furniture sitting inside those rooms. Version 9 staging only cares about how many rooms have malignant furniture in them. It does not care how much furniture is stuffed into a single room.
Okay, let's put that into a concrete clinical scenario. If you are reviewing a P scan and you see 3 highly suspicious, intensely PT-avid lymph nodes, but all 3 of them are packed tightly together within one single anatomic ipsilateral mediastinal station.
Like they are all in 4R.
Right, say they're all confined within the boundaries of station 4R. That is 3 malignant chairs in one room. It is single-station disease.
Yeah.
Therefore, that is clinical N2A.
Correct. But if the imaging shows just 2 suspicious nodes, one small avid node in station 4R and one small avid node down in station 7, that is 1 malignant chair in 2 entirely different rooms. The cancer has established itself in multiple geographic lymphatic zones. That is multi-station disease. That elevates the category to clinical N2B.
Which takes us squarely back to the central controversy in our anchor case today. The CT and the PET show two avid ipsilateral mediastinal nodes. Reader 1 wrote multistation N2 disease in their report.
Reader 1 thinks they are in two different rooms.
Exactly. Reader 2, reviewing the case later, said, no, based on the anatomic landmarks, both of those nodes are actually clustered within a single station.
Reader 2 thinks all the furniture is in one room.
Yes. So this creates a strict clinical mandate for the treating physician. You do not just shrug your shoulders, average the two reports, and guess.
Please don't do that.
You do not just default to whichever note was signed most recently in the electronic medical record. As we will see when we pull out the card, the N2A versus N2B distinction fundamentally alters the final stage group.
It changes everything.
You have to physically go down to the reading room, pull up the source images with thoracic radiology, map the nose against the specific vascular and airway landmarks that define the stations, and document the resolution of that disagreement.
And if the imaging remains equivocal, you must decide if invasive pathologic confirmation like an endobronchial ultrasound and EBUS is required to definitively sample the distinct stations.
Because, as we established in the very beginning, an enlarged or PE-avid node is merely an imaging finding. It is a shadow on a screen. It is not a pathologic fact. It could simply be a reactive inflammatory node from a downstream infection.
Right.
So at this point in our workflow, we have an unresolved N category. We know it is clinically suspicious for N2, but we absolutely need to know if it's A or B.
But before we can translate the final stage, we have to complete step 5, the distant spread, the M category. We have to ensure our distant evaluation is bulletproof so we can confidently say this patient is truly M0.
Why is that so crucial at this exact step?
Because if they are M1, the TNM categories largely cease to dictate the primary treatment paradigm. It's a whole different ballgame.
Right. Version 9 brought critical subdivisions to the M category as well, again based on distinct survival curves in the global data. M1A is essentially advanced thoracic spread. This includes malignant pleural or pericardial effusions, malignant pleural or pericardial nodules, and returning to our mnemonic contralateral lung nodules.
Yes.
M1B designates a single extrathoracic metastasis located in a single organ system. Think of one isolated brain metastasis or one isolated adrenal metastasis, and the entire rest of the body is completely clear.
Then we get to the critical split between M1C1 and M1C2. This is another area where rigorous counting is required, but here we're counting extrathoracic organ systems, not individual metastatic lesions.
Wait, run that by me again?
Okay, M1C1 designates that there are multiple extrathoracic metastases, but they are entirely confined to one single extrathoracic organ system.
So, as an example, if the PET scan shows 3 distinct separate metastatic lesions all located within the liver, but the bones, the brain, and the adrenals are totally clear.
That is multiple lesions, but one organ system. That is M1C1. Precisely. Biologically, that tumor has figured out how to thrive in the liver microenvironment, but nowhere else.
Okay, what about M1C2?
M1C2, on the other hand, means there are multiple metastases distributed aggressively across multiple extrathoracic organ systems. For example, the imaging shows 2 metastatic lesions in the liver and 1 allografic lesion in a thoracic vertebra.
Oh, I see.
The cancer has crossed organ systems, colonizing both visceral and skeletal microenvironments. That makes it M1C2, which generally carries a much more guarded prognosis.
So just like we count stations and not individual nodes for the N category, we count organ systems and not individual lesions for the M1C category.
That's the parallel, exactly.
It's a reflection of the biological behavior and systemic competence of the tumor. Like, is it contained to one distant environment, or is it spreading indiscriminately across multiple diverse tissue types?
Which is exactly why managing ambiguity in the M category is so critical. Suppose a patient has a scan showing several obvious, intensely avid skeletal metastases in the ribs and spine.
Okay, clear bone mets.
But as you scroll down, there's also a tiny, indeterminate, subtly enhancing lesion on the left adrenal gland.
Oh man, always an adrenal finding.
Right. It might be a metastasis, or it might just be a completely benign adrenal adenoma. The current best clinical description is not automatically M1C2 just because there's a shadow on a second organ.
Because we don't know for sure.
Right. The safest, most accurate description is clinical M1C1 based on the confirmed bone disease with an indeterminate possible second organ system. You do not prematurely escalate the stage grouping before that ambiguous finding is resolved with a dedicated adrenal protocol CT or an MRI.
This level of operational discipline is exactly why we implement what we call stop-the-line rules for staging when we run a tumor board.
These are so important.
There are 6 specific clinical situations where you literally stop the workflow, pause the discussion, and refuse to assign a final stage until the fundamental issue is fixed. We've touched on the concepts, but let's lay them out clearly as a checklist for the listeners.
Let's do it. Rule 1. Stop the line if the addition is not explicitly named. We must establish on the record that we are using version 9, otherwise the stage is meaningless.
Absolutely.
Rule 2. Stop the line if a legacy diagram, like some blurry, unlabeled 8th edition matrix someone found online, is being used as a reference standard.
Rule 3. Stop the line if an M0 category is declared, without the decision-relevant distant imaging actually being completed and reviewed. You cannot call someone M0 if the brain MRI hasn't happened yet.
You just can't. Rule 4. Stop the line if N2 is recorded in a clinical note without rigorously distinguishing between N2A and N2B based on station count. N2 alone is completely insufficient for treatment planning in version 9.
Right. Rule 5. Stop the line if a separate pulmonary nodule is casually mentioned but staged without defining its exact anatomic location. Like, is it in the same lobe, a different ipsilateral lobe, or the contralateral lung?
And Rule 6, which is perhaps the most important for patient safety. Stop the line if a purely P-positive finding is being used to drastically change the treatment intent, like moving a patient from curative surgery to palliative chemotherapy without explicit documented multidisciplinary review or, ideally, invasive pathologic confirmation.
That one is huge. So applying step 5 to our anchor case, the dedicated brain MRI was completed, and it is negative. There are no pleural effusions, no contralateral lung nodules, and no extrathoracic metastases seen anywhere on the CT or the PET scan.
Perfect.
So we can confidently say the patient is provisionally clinical M0.
Now we finally arrive at step 6.
We made it.
We have done the hard work of assigning T, N, and M independently. We have a clinical T3 primary driven by the same lobe nodule. We have a clinical M0 distant evaluation. And we have an unresolved N category that is trapped between CN2A and CN2B, depending on the radiologist's interpretation. We now open the official version 9 IASLC staging card to translate the stage group and see exactly why that specific nodal discrepancy matters so much in the real world.
Let's run both scenarios through the matrix. If reader 2 is correct, and the anatomy proves that both avid nodes are confined tightly to a single mediastinal station, our triplet is CT3, CN2A, CM0. Looking at the version 9 card, that triplet translates to stage I5A.
Okay. But if reader 1 is correct and those nodes genuinely occupy 2 distinctly different ipsilateral mediastinal stations, our triplet is CT3, CN2B, CM0. When you trace that on the version 9 card, it translates to stage IIB.
Wow. This is the massive insight that just has to sink in for anyone treating lung cancer. We were talking about the exact same primary tumor size, location, and features. We were talking about the exact same absence of distant disease.
Exact same patient.
Right. The entire stage group shifts from IFA to IB purely based on the geographic count of 1 versus multiple involved mediastinal stations.
And that stage shift is not just semantic. It's not just a letter on a page. It dictates entirely different high-stakes treatment algorithms.
How so?
A patient with stage II disease might be a prime candidate for neoadjuvant chemoimmunotherapy, followed by a curative intent lobectomy. A patient with stage IIB, multi-station disease, is generally not considered an upfront surgical candidate at all and is usually steered toward definitive concurrent chemoradiation.
That is night and day.
This is precisely why you cannot just lazily write stage 3 in your consult note and figure out the details later. So when you are the attending physician, how do you formulate your recommendation in the chart when you are faced with this kind of unresolved imaging discrepancy?
You model exceptional clinical practice by keeping the uncertainty highly visible. You do not hide it behind a confident guess.
Right. What's the phrasing?
You dictate your assessment something like this. I favor clinical T3, clinical N2A, clinical N0, stage IIAA, AJCC version 9. However, this is pending multidisciplinary radiology reconciliation of the involved nodal stations, and we will require appropriate EBOS nodal confirmation if a multistation result would alter surgical management.
I love that. That phrasing is literally a shield for the patient. It protects them by explicitly stating the exact assumption your current stage is based on, while recognizing the specific variable, the mediastinal station count, that could completely change the plan.
It's all out in the open.
It prevents the entire oncology team from barreling blindly down an irreversible treatment path based on one miscounted nodal station.
Okay, let's distill everything we've just covered into highly actionable takeaways, specifically looking at how this complex logic translates to daily clinic practice and high-stakes oral board exams. Let's start with 3 classic oral board traps that examiners use to fail candidates.
Yeah, traps. Let's hear them.
Trap number 1. You look at the pathology report, it clearly says N2 disease, so you confidently tell the examiner this must be stage ITA.
Right. The fatal correction here is realizing that the designation of N2 alone does not determine the final stage group in version 9. The specific subdivision of N2A single station versus N2B multi-station matters immensely, and the stage group is heavily modified by the T category.
Give us an example of that modification.
Sure. For example, a T1 tumor with N2B disease translates to stage IIA. But a T3 tumor with that same N2B disease translates to stage IIB. The cognitive shortcut of linking N2 directly to stage IIA is fundamentally unsafe. You must name the anatomically involved stations, definitively assign N2A or N2B, complete the full TNM triplet, and actively use the version 9 card to find the result.
Perfect. Trap number 2. You see a brightly glowing, intensely avid lymph node on the PD scan and say to the surgeon, well, the PP positive node proves the nodal stage is N2, so you shouldn't operate.
Again, metabolic suspicion is not pathologic certainty. We see inflammatory processes, sarcoidosis, and occupational lung exposures glow brilliantly on PT scans all the time.
So what's the corrective move?
The corrective move is to state a clinical N category based on the imaging impression, explicitly acknowledge the imaging uncertainty in your plan, and state that invasive pathologic confirmation must be obtained before denying a patient a potentially curative surgery based solely on a glowing pixel.
Don't trust the pixel. Okay, trap number 3. I know the old 8th edition stage diagram by heart. I've used it for years, so I can just translate this new case from memory without looking it up.
Relying on memory is a massive liability when staging editions change. Version 9 fundamentally changed clinically meaningful subdivisions, like splitting N2 into A and B and splitting M1C into 1 and 2, and those splits alter the final stage group consequences.
Right.
The corrective move here is incredibly simple and shows real clinical maturity. Always open the current, official card. Double-checking the matrix is a safety practice. It is not a sign of weakness or ignorance.
Okay, those are the traps to avoid. Now let's lay down 6 rapid-fire board pearls to keep your staging logic grounded. Pearl 1. Always explicitly name AGCC version 9 whenever you document or present a current lung cancer stage.
Pearl 2. A missing diagnostic test is not a negative test, and a technically performed test that is non-diagnostic is not an answered clinical question. Maintain provisional categories until the data is secure.
Pearl 3. Assign T, N, and M strictly separately and independently before you ever allow yourself to look at a stage grouping matrix.
Pearl 4. For the N category, N2A means involvement of one ipsilateral mediastinal or subcarinal station. N2B means involvement of multiple ipsilateral mediastinal stations. You count the stations, not the individual nodes.
Rooms, not furniture. Pearl 5. For the distant M category, M1C1 means multiple metastases confined within one single extrathoracic organ system. M1C2 means multiple metastases distributed across multiple extrathoracic organ systems. You count the organ systems, not the individual metastatic lesions.
And Pearl 6. When imaging reports are ambiguous or discordant, do not average them out. State your favorite stage, clearly document the competing interpretation, and name the exact diagnostic test or multidisciplinary review that would definitively resolve the management-changing uncertainty.
Awesome. Let's finish strong with a board blitz. I'm going to fire 3 rapid clinical scenarios at you. I will pause slightly after each question so you, listening at home or on your commute, can commit to an answer in your head before the expert breaks down the logic.
Right.
Ready? Question 1. You are reviewing the imaging for a new consult. The patient has 3 highly suspicious, intensely PT-avid lymph nodes. But your review of the anatomy confirms they're all physically located entirely within the boundaries of one ipsilateral mediastinal station, station 4R. What is the correct clinical N category?
The correct answer is clinical N2A. It all traces back to the rooms versus furniture analogy.
Right.
The absolute number of involved nodes, the furniture does not dictate the category here. 1 involved ipsilateral mediastinal station. The room defines N2A, regardless of whether there is 1 malignant node or 3 malignant nodes crammed inside it. Elevating to N2B would strictly require malignant nodes in multiple distinct ipsilateral mediastinal stations.
Spot on. Question 2. A patient has biopsy-proven non-small cell lung carcinoma, a PP-avid ipsilateral mediastinal lymph node, and no documented brain imaging whatsoever in the chart. The medical oncology consult note reads, clinical N2, M0, stage 3. What are the two glaring structural corrections that absolutely need to be made to that note before treatment begins?
First, the broad label clinical N2 is completely inadequate for staging in version 9. You have to review the anatomy, specify the involved stations, and refine that category to either N2A or N2B. Furthermore, the note assumes PE avidity is pathologic proof, which it is not.
Right.
Second, and more dangerously, you absolutely cannot declare a definitive M0 status without the required decision-relevant distant imaging, which strictly includes a brain assessment. The M category must remain provisional CM provisional until a diagnostic quality brain MRI is complete and reviewed.
Excellent. Okay, question 3. Let's go all the way back to our anchor case. We established a clinical T3 primary because of that separate same lobe nodule. The distant staging is confirmed clinical M0. Initially, the radiology review confirms that only one ipsilateral mediastinal station is involved. That gives us a triplet of CT3, CN2A, CM0, which translates to stage IEA.
Okay, we remember that scenario.
But wait. The surgeon performs an EBUS, and a second anatomically distinct ipsilateral mediastinal station is biopsied and confirmed positive for malignancy. What exactly changes in the patient's stage?
The correct answer is that the regional nodal category shifts from clinical N2A to clinical N2B because of the multi-station involvement.
Right.
And because we have a T3 primary, translating the new triplet of T3, N2B, and 0 on the version 9 card changes the final group from stage IIA to stage IA.
What are the trap answers there?
Well, N3 would be a trap answer here because N3 strictly requires contralateral mediastinal or supraclavicular involvement, not just multiple ipsilateral stations. And M1A would be a trap because mediastinal nodal spread is classified as regional lymphatic disease, not distant thoracic spread.
Very thorough.
Which really brings us to a final reflection on this entire complex process. I mean, we've spent a massive amount of time today breaking down specific categories, millimeter-sized thresholds, and anatomic station counts.
We have.
But the ultimate professional habit we are trying to build isn't just memorizing a staging table. The table will inevitably change again when version 10 is published based on new data. The true, enduring clinical skill is ensuring your stage label never becomes more certain than the evidence beneath it. Staging is the art of rigorous transparency.
That is the perfect takeaway to close on. Keep the clinical uncertainty visible, count the stations, count the organ systems, and never assume missing data is negative data. In our next episode, we are going to transition away from these staging labels and dive directly into the physical anatomy. We will map out the specific nodal stations, detail the surgical access routes, and explore the intense decision-making behind invasive mediastinal staging.
It's going to be a good one.
Get show notes and complete practice oral boards at radoncsmartlearn.com and subscribe for our next episode. Thanks for tuning in.